Welcome to the 3D Players podcast, where we explore personalization in healthcare through advancements in 3D technology. We talk to leaders championing more predictable and sustainable patient care. I'm Pieter Slagmolen, and I'm joined by my co-host Sebastian de Boot.
Today we're diving into the world of high-volume total knee replacement. We'll be exploring how a widely accessible technology, patient-specific knee guides, is enabling surgeons to deliver personalized care in a way that is both time and cost-efficient.
And to guide us through this topic, we're thrilled to welcome a true expert in the field. Our guest today is Dr. Raju Ghate, a high-volume orthopedic surgeon within the Endeavor Health Medical Group in Illinois, USA. Dr. Ghate has been using knee guides since 2010 and has a wealth of experience on how this technology impacts clinical practice.
Welcome to the show, Dr. Ghate. We're delighted to have you.
Thank you, guys. Thank you.
Absolutely delighted to have you here. So let's dive right in. Maybe just to set the scene for our listeners, could you tell us a little bit about the patients that you typically treat and what brings them to your clinic? Why are they there?
I'm an orthopedic surgeon here in the United States. I specialize in what we call adult reconstruction, which is essentially hip and knee replacement, although I stopped doing hip replacements 12 years ago. The typical patient I see is at the end stage, what we would call end stage osteoarthritis, right? So they've had pain in their knee for several years, likely, but they've developed arthritis, which for lay people is a loss of the cartilage or the nice, coating inside your knee that lets us walk around and move around without pain. So they've lost that. They have as much cartilage, as I say, as I have on my head, although this is a podcast and I'm bald, but you can imagine that if you're at home or driving around somewhere. So they've basically lost the cartilage in their knee and they struggle to walk through their daily lives and participate, as an active participant in our world. And the current treatment, after trying conservative care ends, usually with a knee replacement, and that's where I come in.
All right. And following on to that, how do you prepare for such a surgery? Could you take us through what the day of the procedure looks like, and both from your perspective, but maybe also for a patient?
The typical surgical procedure takes about 45 minutes to an hour to do today. It's done with a spinal anesthetic, typically in sedation. The patients are, prepped for surgery. They come into the operating room, and the surgical procedure takes, like I said, about 45 minutes to an hour. These people are often up walking about 2 hours after their procedure, and about 70% of them now are getting out of the hospital the same day, which is a big shift in what we're doing. Obviously, technology plays a huge role in what we're doing, not just in terms of anesthetics and how we're approaching people, but the actual technology to get our implants into that patient in a customized way has really helped us. And the efficiencies that have been born out of that process have further helped us, turn what used to be, a 2-hour, 90-minute procedure into, I first started trying to get these done in under an hour 20 years ago. Now we're getting them, the actual implants into the patient within about 30 minutes. And then obviously there's, closure and, getting dressings on and whatnot. But technology has really been the differentiator in terms of our ability to get people through the process probably twice as fast as we were able to do 20 years ago.
Okay. We'll dive into that a bit more later, I guess. But when we talk technology, I assume that you mean patient-specific knee guides, maybe, and you've been doing that for over a decade. Can you maybe take us back to the early days first? How did you get exposed to the technology?
I started at Northwestern University after practice in a private practice group down there in 2005. So 20 years ago, crazy to think. And I was doing a standard knee replacement and constantly trying to find ways to make us more efficient in the operating room. Now, understand, a university hospital, historically, just by putting university in front of hospital, you're saying we're inefficient, right? They are not high volume efficient places in general. And so really, when I came back there after spending a year at Rush, which was very much a university type hospital, but had figured out the efficiency part of it to some extent, I tried to bring some of that sort of, hey, let's move this along, in terms of getting surgeries done. And we used to have this mantra where if we were going to try to do 3 knee replacements or 3 joint replacements by 3 p.m., which today I can probably do 7 by 3 p.m., but on 2 rooms. But still, the concept back there was let's do 3 by 3. And then eventually we said, hey, let's do 4 by 3, because we're shrinking down the number of surgical trays that we're using as we're going through that process of becoming more efficient. And one of the surgical techs at that time, a woman named Michelle, went to the I believe it was a 2000, must have been maybe the 2010 AAOS meeting or Academy of Orthopedic Surgeons meeting, which was in Las Vegas. I did not attend. I think we just had another child, so I was sort of not going to Vegas that year. And she came back and she's like, I found the perfect thing for you. I went to at that time it was a Zimmer booth before the merger. And she's like, I saw this technology and you must use it because it's going to change your life. And I said, okay. She knew me well and she knew what we were trying to do in the operating room. She was committed to that. And so I think in 2010, I did my first PSI case, ironically, on the X-ray tech who worked in the operating room at Northwestern. And he was really excited about the concept. So it was sort of nice because he had some insight into what we were going to be doing and how we were going to be acquiring these guides and the process. And so he was really into it. His name was Victor, and he had been there for, probably been at Northwestern for 30 years working in the operating room. And so all those times running around the operating room eventually wore his knee out. So Victor was our first patient in 2010, and it went incredibly well. It was one of those technologies where you put the guides on and you sort of didn't believe it actually worked. You're like, okay, this can't be real. Like, this isn't possible. And so we did it. I remember I'm like, okay, I'm double checking this thing because I don't believe this. I remember I put an IM rod up the canal. I dialed it to 5 degrees and I checked my pinholes relative to what those pinholes. I'm like, well, it's spot on, right? So it took the learning curve was pretty quick. It took about 5 or 10 cases and I was in. Mm-hmm. And then it took off for me, but I don't know that it took off the way it potentially could have at that moment.
For the listeners maybe not too familiar with the procedure or technology, can you briefly describe what the problem is that a knee guide actually solves for you as a surgeon and how it works?
Traditional knee replacement involves a series of estimations based off of anatomical norms that have been sort of established over time. It involves instrumenting, what I would call instrumenting the femur, which is basically putting a guide up the hollow part of the femoral canal or into your femur. And we know there's a certain angle that would make your leg, the goal of a knee replacement is to put something in. Well, the goal used to be, in 2005 to put something in perfectly perpendicular to the floor, like a good carpenter. And so there were certain angles you had to resect bone at to make sure that you were perpendicular to the floor when your procedure was completed. And you used to use anatomic landmarks based off of the medullary or the hollow canal of the femur, and that would set your one axis, and then you would set other axes based off of anatomical beliefs about the shape of the femur and how the components should go on there. So there's really just a lot of estimation work going on. Scientifically based estimation, but estimation. And same was true with the tibia. When you would cut the tibia, you were estimating where you thought you needed to be rather than being exact. And what the guides did is basically using an MRI was saying, hey, these are the actual exact points. Mm-hmm. So there was no more guesswork. It took the guesswork out of the actual procedure and gave you something that was a 3D printed guide that basically went on the end of the femur and was mated to that bone uniquely to each patient, mm-hmm. and had the drill holes that we would set our cutting jigs with to do the procedure. So,
mm-hmm. So you mentioned an MRI and you mentioned 3D printing and you mentioned drill holes based on the patient. How does achieving that, what does that process look like? Essentially, it must have changed how you approach the preparation of your patient before 2010 and after you started using the technology. So what's the flow like from your perspective?
The workflow before PSI was you look at the x-rays in your office, say, okay, I got a certain degree of angulation to this knee and I'm going to have to do this and do that. You draw some markings on an x-ray with a wax pencil and have a plan. and then you try to execute that plan. The modern world, we get the MRI, we open the software package that comes with the procedure or with the from Materialize or from the the company, and we can plan our surgery much like we used to plan it on a with wax pencils and a X-ray, but we actually plan it, and then we basically hit send and or print, however you want to look at it, and the guides are printed and they show up in my hands at the time of surgery. Obviously they get to the hospital sooner than that, they're sterilized and processed, but that whole process is now done 2, 3, 4 weeks in advance, and then the guides are prepped and sent and used in surgery versus again using that estimation work. And so it's completely changed the workflow in the operating room. How we approach workflow has changed dramatically over the course of the past 15 years.
You mentioned how over the past 20 years you've went from 3 to 4 to maybe now 7 surgeries. Efficiency has been always a very important focus. Can you explain what the role of a guide, the PSI, is in giving you more efficiency? Like what bottlenecks did you have before? How much time did it take? And
Probably a several-fold answer, and I could probably break them up into categories. The first being just the setup of the room. So you walk into the room now, and I was actually joking about this with our OR manager the other day, that back when I was a resident going through training, the joints arthroplasty or adult reconstruction room, you walked in there and there were 15 trays open to do one procedure, 15 surgical pans open to do one procedure, maybe 12, 15, whatever it might be. And my sports colleagues who were doing, ACL reconstructions and rotator cuff repairs had 5 or 6 trays open. They had what we would call fast turnover, and all the nurses liked being in there because there wasn't that much work because you could open 5 or 6 trays and do a surgery. And meanwhile, if you're in the joint room, you're opening 12, 13, 14 trays. It was so with this technology, because we know what we're going to need before we ever get to the operating room, we now open, I believe, 2 company trays, and then we open 2 hospital trays that would involve, basically a saw, knife, retractor, stuff like that. So that's completely changed. Now the fast turnover rooms are the joint replacement rooms for the most part, or at least my room, because we're opening a third of what we used to open, 10, 15 years ago. So that's one phase. So that turnover, we call turnover time, has gone way down for our procedure. And we've also further enhanced it. In order to get that down, we only open the cutting guide and the femoral size that we're actually going to use. So instead of having a tray with 10 femurs and 10 cutting guides, we now say, okay, well, Sally's going to be a size 8, femur. So we open an 8 cutting block and an 8 trial component, and we don't open anything else unless we maybe need to adjust by 2 millimeters here or there. That saved us time and money. I wish we could quantify how much money, but it's really hard to quantify that. But we now have a cart that has individually wrapped cutting blocks and trial components rather than giant trays that are open for each case. So that's one component of it. So that's the sort of surgical OR component from a hospital standpoint. And then there's the surgeon component, right? There's the actual surgical procedure, which if you think about a surgical procedure as a bunch of hand movements while you're in surgery, the surgeon moving their hand and people holding retractors, the number of hand movements required and instruments required to be passed in and out of the surgical field, I couldn't even tell you what the reduction is, but it is tremendous, right? So the number of instruments I use has gone dramatically down, which means I just don't have to move my body and hands as much, and not as much has to be passed. So the actual surgical procedure time has dropped probably by 20. I mean, over the course of starting this. Now understand, I was 5 years into practice and I was actually doing okay. My what we call tourniquet time. So that's the time that the tourniquet is up while we're working. Before I started doing this, I was probably 45, 50 minutes on tourniquet, and now we're probably anywhere from 24 to 32 minutes on average on tourniquet. So over the course of a day, That's a dramatic reduction in time. Now, the 7 cases, not to confuse anyone at home, we now use 2 rooms, so I bounce back and forth. So that's a little bit of the advantage. But for example, in that first room, I'm getting 4 cases done by probably 2 o'clock now.
Obviously, that's a huge operational gain, all of these aspects. Does it in the end impact the patient as well? Does the patient benefit from these reduced time frames and so on?
Well, of course. So, I mean, yes. So that's another several-fold answer, not to bore people at home, but yes, because we're able to use a shorter acting spinal anesthetic. And so long acting spinal would last 3 hours. Your alternative is something that lasts an hour and a half, hour and 15 minutes. And so we're now able to use that shorter acting spinal anesthetic combined with a local anesthetic. And these people are up walking an hour and a half after surgery, right? Because of the time involved, they wouldn't get up till potentially 2-3 hours after surgery till their spinal anesthetic wore off. So it certainly is impacting the mobilization of the patient, right? And then the other aspect is we're able to customize what we're putting into that patient's body now based on their anatomy, right? We know what we're doing before we get there, which is a tremendous advantage. And we're no longer estimating, we're exactimating, right? So we know what we're putting in before we get there.
Yeah. So the confidence for you is also an important factor that going up.
Yeah, and we can talk a little bit about the evolution of what we're doing, but in terms of planning, but that maybe is something further down the road.
It's fascinating to hear about those benefits, both from an economic standpoint as well as for the patient. Yet we also understand the market penetration globally, so not within your practice, but if we think about all knees being replaced, is for PSI, the penetration of that is probably around 15%. You're obviously super convinced about the technology, and it has proven to be super valuable for your practice. So why do you think the technology that has proven to be so valuable is not more widely adopted already?
This has been probably the great mystery of my career. I think it has to do with, number one, people have inertia. They don't want to change. There's a resistance to change. I think you're going to see less and less of that as younger surgeons come out, because as technology has been rolled out, they are more and more comfortable with adapting to newer technologies. Surgeons of the generation, probably my generation, is depending on where you trained, would impact your willingness to use technology, right? So I'll give you a great example. I trained at Northwestern, and there were 2 gentlemen, a guy named Dave Stulberg, who you probably know, maybe have heard the name, and another gentleman named Rick Wixon. And they were really pioneers in computer assisted surgery, right? So they were using casts, with sensors and trackers and everything that sort of has been the next generation has been PSI and robotics, right? In theory, right? Version 2.0 is where we are, or maybe even on to version 3.0 actually now in the past couple of years. But version 1.0 was those guys, and I was a resident watching them do that. And I will tell you, I had no idea what the hell they were doing in the operating room, but I was certainly exposed to the idea that there's this computer in this operating room with us that is somehow helping, in theory, this surgeon put this knee in better, right? And so that concept of, hey, technology is your friend, was sort of imprinted in me when I was a resident, right? Now, go across town to Rush, which is a very prominent, well-regarded joint replacement institution in the United States, and they openly mocked technology, right? They were like, this is so stupid. You don't need a computer to put this in, blah, yada, yada, yada. They were sort of the grunt, like, just do it the old fashioned way, right? That sort of mentality was pervasive throughout probably the first decade of this century in terms of our sort of culture within the arthroplasty world, right? Within the joint replacement world. And so there was a lot of inertia to never accept technology and the need or use for technology. And I would say that generation, which is really my generation to some extent, I would say probably now 50 to 60% of us use some technology, but 40 to 50% are still using old traditional knee replacement surgery as their go-to, right? Which is sort of crazy to me, but I guess to them, it's sort of they don't want to change. And then the next thing that has been interesting on this technology front is we have a fellowship here. So we have 4 fellows that are at Endeavor Health with us here in Skokie, Illinois. And years ago, I mean, and we have every robot under the sun here and every technology under the sun here. So we have PSI, we have ROSA robots, we have a Cori, we have several Mako robots. And so we are doing everything here is, I think almost every procedure done at our institution by the people in my practice have some technology going into that joint replacement. And so and we were a fledgling program when it came to fellowships, but what really drew people to us was like, oh my God, they have every technology there. And so we're very technology forward, and the people we are now training are basically going out there with a technology background. And so I think there is just so much inertia to not change around when this technology came out that it's almost like it needs to be relaunched with a new generation and a new look at these younger surgeons who have now a appreciation for technology that I had, but I was unique in that sense.
Let this podcast then be a milestone in going through that journey and teaching the younger generation. You already mentioned the robotics and the ability to use multiple types of technology in treating patients. How do you decide which technology is right for one specific patient or situation? How do you choose which technology to use where?
This is a little bit of my inertia, but also a little bit my desire to be efficient, right? So I use a patient-specific guide on every patient I can get that done on. And so that's anyone who doesn't have hardware that's close to the knee, or anyone who doesn't have a pacemaker or is severely claustrophobic that would prevent the MRI acquisition. And so I would say I'm probably about 80% using 3D printed guides, and I am 20% using robotics at this point because of the reasons that I before mentioned. That's where I am in my practice. The reason I'm there is it's still more efficient to use the PSI guides. And now that we've gone to version 3.0, as I was alluding to, which is the modified kinematic approach, where that we can essentially do exactly what they're doing with the robot in terms of like predicting where to put a knee now based off the patient's anatomy and their scan. Now that we're making those changes and able to do that with the PSI guides, there's not a ton of advantage, I think, in my mind, to robotics versus PSI. And it's an extra 10 minutes of acquisition of acquiring the knee essentially from a acquisition standpoint in the operating room with the robotics that I don't want to spend doing. And so.
Okay, makes sense. We're also seeing a shift in healthcare towards outpatient treatment centers. And these often smaller facilities have different economic and spatial constraints. Do you see there certain advantages, disadvantages of using guides versus robotics?
Why are we at 15%? I mean, this is where it's shocking that we're at 15%, right? Because as I was alluding to, the number of trays we now open is less than my partners open to do a sports case or an ACL or a rotator cuff because of this efficient care model that we've sort of developed, which some companies were championing early 2015's era, but sort of went away from as they really turned their focus to some of the robotic stuff. But there is no better technology for a surgery center from an efficiency standpoint than PSI guides, in my opinion. From the setup of the procedure to the space you need to do it, you can certainly do these procedures in a smaller environment. To bring the robot into a room, they're not tiny little microphones attached to your table there. They're a large device with a significant structural space that requires a larger environment to operate in that some of these surgery centers don't have. Again, this falls into the great mystery of marketing and how this sort of technology is, in some respects, slipped through the cracks at this point.
You mentioned a lot of the benefits in the OR and also talked about the benefits for the patients. The predictability that guides allow might actually also enable medical device companies to change how they operate, how they manage their stock, how they organize their supply chain. With the experience that you have and the amount of knee guides or technology that you use, are you seeing this happening? Have you noticed changes in how they manage their logistics?
I know here locally they manage their logistics differently at our hospital due to the PSI guides. I have always thought that was sort of the big win for the company was if you know 3 weeks in advance that Mrs. Jones needs a size 7 femur at Skokie Hospital at 2 o'clock in the afternoon, you can really start changing how you move your implants around in your inventory, because obviously the more specific you can get on your inventory, the less inventory you need to have. I just don't know that the companies have really gotten that granular with their knowledge base. And frankly, with robotics, they can get closer, but often with robotics, they don't know exactly the size potentially, or that correlation between scan and size may not be perfect until you get to the operating room. So, but I do think, yes, of course, these are the things that you try. I always tell people, when we talk about this technology, it helps the surgeon, it helps the patient, it helps the company. Probably the only person it doesn't help is the insurance company, but that's their problem.
Well, if it helps the patient, then you would assume in the long term it also helps the insurance company.
You would assume that, yes, right. It's one surgery and done rather than potential for extra, potential revision procedures, right?
Looking into the future of this kind of procedures, a critical part of a successful knee replacement is also managing the soft tissue around the joint. And so much of the current planning is based on the patient's bony anatomy. How do you take soft tissue into account today, and what role do you see it playing in the future of surgical planning?
I've moved to a modified kinematic approach. And so what that means is we're taking into account into our plan the patient's preoperative alignment and likely natural alignment prior to, disease, right? So if someone was bow-legged their entire life and as the disease progressed, they went from 3 degrees of being bow-legged to 13. Well, in 2010, I was putting that person at 0 degrees in terms of being perfectly straight. Now my goal is to put them back to 3 to 4 degrees. And so the ability to dial that in with the guides has reduced the amount of soft tissue work that I need to do probably by about 90%. I mean, it's, again, as I was mentioning with our fellows, I used to do a medial release and show them how I did that. And I would do that 3 or 4 times a day, and they would, learn to do it. Now it's almost like, hey, I got a medial release I need to do. You should watch how I do this, because it's like once a week or once every other week, right? Mm-hmm. So some of those reasons to do certain things in terms of releases have gone away because of our ability to be more comfortable with a modified kinematic approach and where that's putting people. And I would tell you that patients are happier with a modified kinematic approach because they feel like they're getting back to their normal sort of, this is what I looked like when I was 35, not like this is my new me, which feels really weird. As I always used to joke, when we were done back in the 2000s, you couldn't wear corduroys because we put you so straight that your corduroy pants would make noise as you walk down the hallway. So we've gone away from that now. People can wear corduroys again.
So is that what makes patients happy?
The ability to wear corduroys? No, I do think, as I alluded to, I think putting them back to where they sort of felt like they were naturally in their 20s and 30s is sort of, I think, a better place to be. Mm-hmm. And I think that the technology, the implants have allowed us to go there in terms of durability. And now the technology, PSI and 3D guides has allowed us to put them there.
Mm-hmm. Okay. With the evolution that you described for patients, obviously our goal, maybe a shared goal, would be to find a way to bring this technology into the hands of more surgeons, going way beyond the 15%, and then ultimately benefit more patients. What do you think needs to happen to realize this? And is there another evolution for guides needed to really make this shift move forward?
I think there's a couple. Yeah. I've racked my brain on this one, to be honest. There's a couple challenges I think that people face. If you look at our fellows who leave our program, most of them who leave our program are like, oh, I'm going to do PSI knees when I get out. This is easy. This is like a no-brainer. Like, love this technology. And then they get to their hospital system And the hospital says like, whoa, 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 we're not paying for this technology. What's this MRI? How do you get this MRI? Is there an insurance loophole that won't let you get the MRI? I mean, we sort of have that all figured out here. We don't get any rejections on our MRIs. We institutionally, if you take the cost of the guide, minus the, I guess the profit's probably not the right word, but the plus side of the MRI, you're probably coming out net neutral.
Mm-hmm.
Right. And so the problem is hospitals don't think like that. Like they have the Department of Radiology and they have the Department of Surgery. And the Department of Surgery is like, well, I'm down, X $100 for this guide. And the Department of Radiology is like, I'm up because this idiot's doing this, using these guides and pumping MRIs through us. We love this. And so it took me when I got here, because I moved institutions from Northwestern to where I am now, which was North Shore, is now Endeavor. It took me basically getting those two people in the room saying, hey, you're making money, you might be losing money, but we are all doing fine. Mm-hmm. And so getting institutions to look at this as a we can be beneficial. The problem is with surgery centers, they don't have MRI machines often, and the MRIs are being done potentially at the surgeon's office. So the surgeon's office is like, hey, these MRIs are great. And the surgery center is like, hey, why are you making me pay for this? Now, this goes back to something you alluded to, which is quantifying the savings of the technology. Mm-hmm. Right? I think really like we need to find a way to quantify what this technology does from a financial standpoint, right? So what does it save us to not open 2 or 3 more trays worth of trial implants? What does it save us to save 10 to 15 minutes in the operating room, not just on the actual surgical procedure, but on the setup? What does this look like from a savings standpoint to justify the cost of those guides, right? And so the issue there is institutions are very ambiguous about what those savings look like. And as I've gotten involved with administration here at Endeavor, frankly, can't even figure out how to account for it. Mm-hmm. Like they just are like, well, yeah, that sounds great. And yes, we're saving money, but I have no idea how to tell you what we're saving because we actually can't get that granular to tell you what that number is.
So it needs a holistic perspective, but at the same time, better data perhaps to try and quantify the value.
Right. And I think that the companies who use the technology need to sort of commit to making this part of their pitch or their menu of options of how to do their knee replacements. Mm-hmm. Because of the success of the Mako, it caused a lot of panic amongst other companies to really throw a lot of investment and noise at robotics because they felt like every patient's, oh my God, I need a robotic knee. They heard robots, it must be better. Robots have to be better than humans is sort of this, mantra that gets out there. And I think that now that we've sort of survived that, the technology continues to be used despite the now prevalence of robotics. I think it's worth another sort of, hey, where does this fit into the portfolio of what companies offer and where should this ideally be used? And companies saying, hey, we can't get a robot into this surgery center, but let's talk about how we can get PSI guides into the surgery center. And as I think as people get, this next generation of surgeons gets into their careers, there certainly will be more of an appetite to use technology than there has been with my generation and clearly the generation before me.
We now talked heavily about one specific application for a personalized device in orthopedics. Do you see other applications where personalization makes sense? It can be a guide, but also a personalized implant. Where else do you see value of personalization in orthopedics?
Well, I mean, obviously in other procedures, right? I think you're doing it in shoulders, right? It's being done in ankles to some, total ankles. I don't know that there's a hip application at this point. But yeah, I mean, in terms of personalized implants, I think that gets a little dicey. Mm-hmm. I don't know that there's a role for that. You were asking earlier, though, in terms of personalizing, I do think there's potentially a role with the improvement in 3D printing of actually printing these guides actually on site to speed that process along. And I don't know what that looks like, but I certainly think in high volume places, that's potentially an attractive option. How do you print these things? I'm doing 600 of these a year, 500 of these a year. Is it worth printing those locally? And what does that look like? How do we take some of the shipping concerns or some of the transport concerns out of what we're doing because we have a printer on site or a printer locally somewhere that's sort of pumping these out? And I think that's potentially how you partner with institutions. I think that's potentially how you make it intriguing for institutions. Like, hey, we're going to print this stuff at your hospital, right? We're going to bring this right to your front door, and you're going to be able to market this as like, hey, this is being printed like here. Like this is how technology forward our hospital is. I think we went down this rabbit hole a little bit a couple of years ago of talking about that. And I think it's worth going back to stuff like that to see if there's ways to get this technology closer to us, right? Because you guys are in Belgium and I'm here, right? And your engineers are all over the place that are processing these things. And so the ability to say, hey, this just needs to get printed at Skokie Hospital, and my sales rep, Jordan, just goes down there and picks it up and puts it through the sterilization process with our central supply. That's sort of a pretty cool concept to start thinking about. Have you guys thought about it?
There are many areas in which hospitals are printing in-house at this point in time. For this application, if the main motivation would be to reduce potential barriers of bringing them to you faster, maybe there are other ways of achieving that are more efficient than trying to print them in-house. For other applications, it seems very favorable to still do 3D printing in-house. So it's really on an application-by-application basis that we need to look at this. That's my perspective, at least.
From a hospital standpoint, that's a pretty cool thing to market, right? That you can print this thing. You put that printer in the lobby. It's a showpiece. That's like, hey, this is Orthopaedic Hospital. We're doing this. We're so good here that we're doing this stuff here. It like almost becomes like the lab becomes part of the overall marketing feel of the place.
Yeah, there is a marketing value, and a lot of hospitals see that. There are obviously also quite some complexities in terms of doing this operationally, safely, qualitatively, reliably, and within compliance is a huge challenge in many ways. So I think it's finding that balance between how much value does it offer to be able to say you do it in-house, and in terms of operational gain versus how much is the hassle that will come with that. It's a discussion that we obviously regularly have around all products that we make, is what's the best place to make these things? Is it the best to make it in-house within our factories, or is it the best to enable others to build them in-house? I think it's a continuous discussion, and 3D printing is wonderfully placed to actually allow both scenarios. Closing in on the end of our discussion, it was, at least for me, incredibly insightful. What I take away, among other things, is the huge operational gains that you describe by using this technology, and the time savings in the operating room, going from, I think I wrote down, 2 hours to 45 minutes over that extensive history that you described, which is really very impactful, I think. And Sebastian, maybe on your side, what do you take away?
I definitely agree, Peter. I think the fact that the surgical guides still provide you more efficiency than what you have for the robot, I think was also interesting to see. And then I think just the mystery of why we're not able to drive adoption more, I think, and where probably there's a key in trying to find a way to quantify the value, knowing that this is not so easy with how institutions are set up. But I think if we could think about ways to do that, and as industry maybe play a stronger role in making it easier for the hospital to understand the total value it brings, we would probably be a step in the good direction.
Thank you so much, Dr. Ghate, for joining us today. It was a wonderful conversation. It was a pleasure to have you share your extensive experience and expertise. So I truly enjoyed it.
Thank you, guys.
This was 3D Players, the podcast where we delve into the latest trends and innovations in personalized and sustainable healthcare. We were your hosts, Peter Slagmolen and Sebastian de Boot. If you enjoyed this episode, be sure to check out our series for more valuable insights, and make sure to subscribe. If you have any questions or suggestions, you can also drop us an email on medical@materialize.be. We appreciate your time and look forward to having you with us on the next episode. Thank you for listening.